So is it being seen in other countries or is it peculiar to India? Deborah, I'm talking about COVID occurring after first dose of vaccine, second dose of vaccine, and then I have 7 patients who had COVID, vaccine 1, vaccine 2, and now COVID again, including my wife. She had COVID, she took vaccine 1, then vaccine 2, and now she has again developed COVID. And the fourth COVID is more of a thromboinflammation than inflammation. So Deborah, what is the situation there?
Yeah, here in Brazil, we are giving vaccination for the people, but very slowly because we don't have sufficient doses for the people. Now we have another Minister of Health, and I hope that he will make a good work, a good job. He's an excellent doctor. He's my personal friend, my friendship. And I hope that he will work very good, very well. He's an excellent medicine doctor.
Okay. Dr. Akhtar. Dr. Akhtar.
Good morning, everyone. Dr. KK, thank you very much. In South Africa, 275,000 Johnson & Johnson vaccination is given. So far, only 20 minor side effects reported, and 1 allergic reaction was admitted for 24 hours, and no report still came out clotting issue of Johnson & Johnson. So we are all waiting for and monitoring the cases, if there are any. But now,
after clotting is an issue which is my next agenda. But at this moment, I want to know, are we seeing increased number of COVID cases after receiving vaccine? My concern is, I said yesterday I had a meeting with 500 such patients in India who developed COVID after receiving the first vaccine. So are we seeing it any other country? Then I will share what we are seeing.
In South Africa, we haven't got any report that after given the first dose of Johnson & Johnson, anyone developed COVID.
Bangladesh, Dr. Chaudhary, do you see any increased number of cases of COVID after vaccination? And you have to unmute yourself. International faculty may kindly unmute themselves.
Sorry, thank you very much, Dr. Jawahar and everybody. Good morning. Here in Bangladesh, so far, vaccination has been given to near about this is 5.6 billion people. This is the first dose, and the second dose also has been given to near about 1.4 million. So this way, actually, we are hearing, but actually there is no such statistics here in Bangladesh. We are hearing yes, somebody after vaccination also they got COVID, and it definitely is because just a second dose has been given only 1 week before. So after second dose, we do not know. Actually, we have to pass more 14 days. Then after the 14 days, we have to see that those people are getting it or not. But after first dose, actually, yes, a lot of people, which is actually expected. Actually, I don't know because this is.
Dr. Chaudhary, I will come back to the certain observations. At this moment, we are only finding out: are we seeing cases of COVID after first vaccine? We will be now discussing whether they are primary COVID or a breakthrough COVID. But at this moment, we are seeing in India, I mean, I have seen more than 500 cases they have reported to me that they have developed COVID after receiving the first vaccine. So we will discuss now whether antibodies are formed or not. That's a scientific answer. So at this moment, Pakistan, are we observing number of cases increasing or reporting after they have received the vaccine, the cases of COVID? Dr. Sajjad? Okay, he is at the moment.
Hello, can you? Hello,
Yes, yes,
hello.
yes, Sajjad.
Thank you very much, Mr. President. Actually, as you inquire about the COVID patient after having a first dose, in fact, we don't have any cases reported having coronavirus involved in the coronavirus, suffering from coronavirus after having first dose of vaccine. I have tried day before yesterday from the government that do you have any cases reported to you that the virus has been infected to those who have the vaccine, first vaccine. So they have said that they don't report, they don't have any reports. So in Pakistan, near about, I think, uh, uh, 10 million, 10 lakh people, I mean, 1 million people have been vaccinated till day before yesterday, but nobody have reported as any post-infected coronavirus.
So we are seeing one peculiar thing we are seeing is in India, those who have received Covishield, we are observing a spurt in number of cases. We have seen a spurt in number of cases after receiving the first or the second vaccine. That's one thing. So this observation so far has not been noticed in other countries. That's one observation, Dr. Sanchita, to write. Number two, now what is peculiar in this is when you get a COVID after first vaccine, it can be, number one, you were carrying, because there is a wave, very rapid wave of mutant strain going on in India. So one possibility is you were carrying an infection. The second is you acquired the infection in the vaccination center. And the third is you acquired the infection after the vaccination. Now, these cases, what we are observing are predominant in the first week. They are predominant cases in the first week. That means once you have got the vaccine, in the first 7 days, you are getting the COVID infection. And what we are observing them is that many of them have a significant lower CT value in the RT-PCR, which means they have high rate of transmission. So I'm putting a hypothesis for other countries to observe. Can vaccine, I'm talking about can vaccine, obviously in India it is Covishield, can vaccine precipitate the entry of the virus in my body, or what it called as a disease enhancement. So the disease enhancement we used to see in dengue, where My third thing, which I want a consensus today, I want a debate today. All over the world, people are saying that Johnson and Johnson, they are talking about now all vaccines. Forget about Johnson and Johnson. Forget about Covishield. Forget about, they are all talking about all vaccines in women who are menstruating. Some people say 18 to 48 years. Some people say less than 65 years. So I would say all women who are menstruating or on HRT or HRT. That means they are taking some sort of HRT. They have more tendencies to develop clots. And now some people are saying don't give them. Some people are saying ban them. I am proposing a statement that, and I have talked to at least 10 to 15 senior gynecologists in my country. And my proposal is all menstruating women, all women on HRT, if they are given a vaccine, give them prophylactic aspirin, 75 milligram, then the chances of getting that rare clots become zero. So can we debate on this particular issue? Can we give aspirin 75 milligram in all menstruating or on HRT women to prevent cerebrovascular thrombosis, splanchnic thrombosis? My wife is 63, 61, and she developed a very high rising D dimer. I had to give her anticoagulation. So she developed anticoagulant disorders. So can we consider based if no contraindication? So I says if no contraindication, I will say consider. So I can't say give it. Consider aspirin in all menstruating women or women on HRT. So for me, women on HRT will take it to up to 65 years of age. Can we consider this? If no contraindication, consider aspirin. Can we have a debate on this?
Hello, Mr. President. Can I just ask that how many days before giving the vaccine, how many days you start aspirin 75 milligram?
Aspirin, if you take your dose just now, your action will start within minutes, and your platelets will be out for the next 72 hours. So it can be started.
So before, 24 hours before having this vaccine.
Now we have to understand the concept of day 5 and day 3. Day 3 is a day for inflammation, and day 5 is a day for thromboinflammation. So aspirin has to continue. If you give it only stat dose, it will not. So it has to continue for 2 weeks minimum. So if you get, I am normally saying that if you give aspirin to people who are going for vaccine, take the aspirin, continue it till 15 days after the second vaccine is over. Aspirin is not going to harm. It's a 75 milligram if no contraindication. So yes. If no contraindication, women going for vaccine to prevent. So what will happen with that is everybody is relaxed. In India, it's less than ₹1 tablet. It's not costly, and it is going to prevent you from many other things. So if you take aspirin, 1 tablet, 75 milligram, it may prevent. So that controversy of clots may be over. All over the world, people are talking about don't take this vaccine. So I say take this vaccine and take aspirin. That's all. I'm not talking about heart attack at the moment. I'm only talking about the controversy of clot. Now, I have gone through with a lot of experts, and I'm very clear. Clots are formed only after platelet aggregation. And platelet aggregation is because of neutrophils. Neutrophil aggregation is PGF beta aggregation, and it is TH17 aggregation, not TH1 aggregation. So without going into the details of the mechanics, aspirin can prevent platelet aggregation like in acute MI. So if you give them simple prophylactic aspirin, the problem of clots can be over. Now, this is something where people where vaccine needs to be given, and you are not giving it because it is contraindicated. Now, US can say, I will not use Johnson and Johnson because I have other vaccines. Some of the European countries will say, I will not use Covishield, I have other vaccines. But people like India, Pakistan, Bangladesh, we have no choice. We will only use vaccine which is available. So in India today, you can't afford to ban Covishield. So vaccine will produce the same. That's my assumption. I have no data on Covaxin producing the clots. Covaxin or Sinopharm is the same, but there should be no difference. Once your protein is causing thromboinflammation, when the virus is causing thromboinflammation, the dead virus will also cause thromboinflammation. So this will be a generalized statement, irrespective of the vaccine. Take aspirin to prevent thrombotic clots. It's a very bold statement I'm making, but to end up the controversy in various countries, stop it, stop it, stop it. Yesterday, every country now is saying risk versus benefit assessment. No country is saying give vaccine. Every guideline says benefit versus risk. That cannot be of a at this moment, my discussion is only for the women, because this is what the internationally they have come out, that women between the age of 18 and 48, some people say less than 60, some people say less than 65. So if I combine all of them together, they all get fit into one thing, and that is sex hormones. So all those who have estrogen and progesterone in the body, they are on OCP and they are high risk for coagulation. Because they are at a high risk of coagulation, give them aspirin. Now we are giving them, all pregnant ladies, we are giving them aspirin for IUGR. That's again thrombosis. So if you are prone to thrombosis in a female, give them aspirin. That's the recommendation. I'm going to put it forward from CMAAO. I'm not putting it down. I said, if not contraindicated, consider. I'm not saying give it. When say consider, it becomes case-to-case basis. Now I come back to next situation. And the next situation, yes, Anjali.
Okay, sorry. My hand is up, so I'm sorry to this. to interrupt. I just would like you to, I'm not sure whether you guys going to explain this, but just to explain to the people here that the plotting that we are talking about of the 6 people out of the normal pulmonary embolus or DVT that you will be able to see. Thank you.
Okay, very good question. She has put it. Now she wants to go into the mechanics of formation of a clot. Okay, so we need to understand the mechanics of formation of a clot. I will go to a classroom discussion. I will go to a classroom discussion here. Now I have drawn, and she is right in discussing this particular issue. So I have a cell, and I have a virus protein. I have a virus protein entering my cell. Now body will try to get rid of this viral protein, okay, outside the cell and inside the cell. On the cell membrane, there will be TLR. Inside the cell, there will be NLR, and there will be inflammasome. And they will try to kill the virus protein or the spike protein. Now this response is inside the cell. Okay. This cannot cause thrombosis by itself unless it explodes. These spikes outside my cell, spike proteins, will be killed by Th1 response and Th17 response. So these are the spikes. Th1 response will recruit lymphocytes. These are called CD4 and CD8 cells. Their job is to make macrophages or release interleukins to get rid of this material. This is a standard discussion we have been having for the last 1 year. This is a classical representation of Th1 response. Now, what is happening here is after the vaccine, we are getting Th17 response. Now, Th17 response normally is a response which recruits polymorphs. Now, this normally we are supposed to see in bacterial and fungal infections, but we are seeing it here. And when they recruit polymorphs, so the polymorphs comes here. When the polymorphs comes here, they release a substance called NET, and they make like a makdi ka jal, what we call them in spider net. So they create a net all around that, where under that net, they try to have all the spike proteins into that net. It's like a fish net. It's like a spider net. That spider net is produced by neutrophils. And once this neutrophils, you get rid of spike protein with the help of neutrophils and not lymphocytes. Now, all of us today have seen a concept called NL ratio of more than 3.18. When your neutrophilic count is high and lymphocytic count is low, we say these are serious patients. Now, there are two situations. Either N is normal and L is low, or L is normal, N is high. That depends upon the pathogenesis. So what I am talking about is that this pathogenesis where there is an accumulation, you cannot form a clot without activation of platelet factor 3. It is the platelet factor 3 which causes the formation of accumulation of platelets. Platelet factor 4 antibodies, which are now being detected, are the ones which are forming the clots. But aspirin will still act because it will block platelet 3 factor. So for prevention of this, aspirin will still act. Once you develop the clot, then you use non-heparin, warfarin, or other anticoagulants. Remember, once the clot forms, you have to use non-heparin oral anticoagulants. So I agree with Deborah that aspirin, number one is, it is rare. It is reported rare. I am not saying it's rare. It is reported rare. But if you do all these patients D-dimer, and so what we are doing clinically is, so we are checking on day 3. So I've said day 3 and day 5 sutra. On day 3, there is a inflammation, and on day 5, there is thromboinflammation. So if your CRP is high on day 1, you will start rising, D-dimer will start rising on day 3. And on day 5, you will have platelet reduction. And that is the time for formation of the clot. The clot will not form before 5 days. So the clot will only form in less than 5 days. And the classical definition of VIT, which is vaccine-induced thrombocytopenia, is rising D-dimer and reducing platelet count. That is the definition. And that platelet count on day 1, if I give aspirin, I will not allow platelet to aggregate. I will not allow platelet to fall, and I will not allow thrombosis with bleeding. So that's my assumption, which I am saying. If you give aspirin on day 1, you may not end up into a clots and other drugs on day 5. Remember, very clear, vaccine-induced thrombocytopenia is ruled out if you get it in less than 4 days. It has to be between 4 days and 14 days. If it is occurring after 14 days, it is not VIT. The autoimmune response is only seen after 4 days, less than 14 days, and that is characteristics is low platelets because of overconsumption. That consumption can be reduced by giving aspirin. So that explains TH1 response, TH17 response. So now I'm coming back to, should we give aspirin to all comorbid people irrespective of the age? Now I'm coming to, forget about even vaccine. I'm talking about even COVID. Should we give aspirin in all comorbid people on day 1 if they develop COVID, so that they don't end up into any COVID clot or a vaccine clot? Any comments of anybody? Should we think of giving aspirin? I'm going back to the UK suggestion long times back that aspirin should be given to everybody above the age of 50. So once UK made a statement of a polypill, and they said more than 50 years of age, everybody should be given aspirin, if not contraindicated. Do you think the time has come for us to consider that in all 50 plus comorbid people in the COVID era, we give them low dose aspirin. So first of all, I have no interest in any pharmaceutical company. I am not promoting any aspirin. Aspirin in India is generic, available at 1 rupee a cost, less than 1 rupee a cost. So no pharmaceutical company is behind it. So I'm talking about aspirin, low dose aspirin in comorbid people to be given A, before, during, and after COVID, B, during and after COVID. That's a matter for debate. Anybody?
Okay, Angelique here. I think one needs to look at the admission rate in ICU and see whether whether some of those patients already took aspirin due to some of their comorbidities. I know that aspirin is one of the of our guidelines, one of our medication that we will use if you are diabetes or having previous cardiovascular incidents and you are on chronic medication. That will be one thing. So I think one needs to do a literature search, and also, ICU would be the easiest to say this patient has been taking aspirin for the last 5 years and then unfortunately also developed clotting when having COVID-19 and hospitalized. I think one needs to see what is maybe being written and alert all the people. It's great that you alert us so that we can apply our minds going forward and looking out for patients already on the aspirin, unfortunately develop clotting. But again, as I've said, that we need to look at the data. Thank you.
So I will come back to why I picked up this issue. This issue, why did I pick up? When I was talking to a couple of seminars with the US people, and they said every admitted patient needs low molecular weight heparin. So I started thinking that moderate to severe patients of COVID-19 should need low molecular weight heparin. And then I suddenly went through, there were no home isolation guidelines there. Every patient was being admitted. So then I came back and started studying. Even mild cases, they were giving low molecular weight heparin. And now, up till now, I never brought this point for discussion till the controversy came that COVID and COVID-19 vaccine involves a pathogenesis of heparin-induced thrombocytopenia. Now, all over the world, they are talking about non-heparin anticoagulation. If the vaccine is causing vaccine-induced thrombocytopenia, the main virus ought to cause that. So I have no data now to say, I'm retrospectively now talking about, should we really give low molecular weight heparin, or we give them newer oral anticoagulants, non-heparin anticoagulant, or just start aspirin on day one and prevent any type of clotting formation? Because we have not been able to reduce the mortality all over. The only thing which has been able to reduce the mortality is steroids. We have not been able to reduce the mortality with low molecular weight heparin started on day 5. Is there a scope for starting aspirin, old drug aspirin, 75 milligram on day 1, maybe that all the clots formation may get, MI, heart attack, everything may get, because we all know that this macrophages one precipitate vulnerable plaques. Clots are forming all over. It's a thromboinflammation. So instead of treating thromboinflammation by heparin or non-heparin anticoagulation, can we prevent thromboinflammation? Anybody? So I'll come back to a few more points, which I have put it down for discussion. So now another thing for observation is, after vaccine, what we are observing is, if you are developing a corona, it is cough. So the patient says, I'm having throat irritation. I don't know what is, this is an anecdotal observation. These are observations that post-vaccine corona is always presenting with cough. It's always presenting with cough. The classical feature is throat irritation. So the another point I'm going to talk about is, should I go to identify, see that the corona, the virus or the protein is putting my body into fire. So there is a friendly fire and there is a unfriendly fire. And the friendly fire is C-reactive protein. Now at this moment, everybody is after PCR. So let me do a RT-PCR. Till the report comes, no treatment. So your body is on fire, your house is on fire, and you are after the thief. That till the thief is detected, I'm not going to treat. This policy, I want to strongly object. Start the treatment like an MI. In heart attack, you don't wait for confirmation to give aspirin. You say, you suspect aspirin, you chew aspirin, and then confirm the diagnosis. Similarly, in COVID, I am saying, awaiting report of PCR, start the treatment on the basis of CRP, which is C-reactive protein, which is a sign of inflammation. So I say, do CRP, then PCR to prevent CPR. CPR is death, cardiopulmonary resuscitation. All have the same three words. So instead of waiting, because in India today, RT-PCR waiting period is huge. Today, yesterday, the admission, hospital admission waiting period is 700 per hospital. 700 people are on the waiting list to get admitted. 100 number waiting list. RT-PCR is not available. People says we can't do it. We have no capacity to do it. So should we start relying on mitigation, which means that if a situation comes where number of cases are high, mitigate, treat them on CRP and treat them clinically. Now, I will now come back to situations in, I want to listen to China, Singapore, Korea, then Taiwan, that what are they doing that they are not getting affected at all. They are not seeing clots, they are not seeing inflammation, they are not seeing the number of cases. Something is being done, something is peculiar about these countries, China, Taiwan, Hong Kong, Singapore, Korea. So these countries have practically, they have been able to save themselves. Can we find out what's common there, which can be adopted by other countries? Dr. Chong, and then Dr. Chan.
Afternoon, President. I think, well, we've got a situation under control with public health. So the number of cases are very few. The other thing is that, we have much lower incidence of thrombosis compared to Western countries.
That you said.
Yeah, so.
That you said earlier also, sir. That you said earlier also that the maximum chances of inflammation are in European countries. Thrombosis are in European and US companies. India is in between. And these countries have minimum chances of thrombosis. So I'm not discussing thrombosis and inflammation at all. I'm only going to say is you may not get thrombosis and inflammation, but you can't say that Singaporeans don't get the virus. Why you are not getting it cannot be only a public health, because if it was a public health, then Europe would have also be able to control it. There has to be something we are missing. What is protecting this segment of the world from getting severe COVID or no COVID at all? how come China has been able to control it? When we say it is going to infect everybody, Chinese vaccine cannot be the answer because that's a dead vaccine. You can't say China has been able to control it because they have a Sinopharm vaccine, because that's a dead vaccine. That vaccine will not give you an efficacy of more than 50%. You cannot say they are a low density. They are more density than us. Number of people, population-wise, they are more. So there has to be something we need to find out the answer so that others can do that and prevent it.
I don't have any answer for you, President. Maybe Alvin does.
So one thing we can do is we can export 50 of you in India and see whether you develop COVID or not. Then you can say we are genetically different. No, I'm only trying to say that are Singaporeans or Hong Kong people or Chinese people living outside their country, are they developing the infection? That's my question. So do you feel that Korean people settled in US or Singaporeans settled in US, are they behaving differently? I don't know the answer. So this is what I am asking. So are Chinese people settled in US, are they getting more infections or less infections? Then we start discussing on marrying a Chinese girl or a Singaporean girl so that our children are saved in future.
Yeah, sure. I think you have a very good insight, Mr. President. And however, of course, because of the sensitivity of the issue in America about the ethnicity, you know, I don't know whether they are carrying out such studies in America, but definitely I had come across a pediatric study in UK. In UK, of course, they have the multi system inflammatory syndrome in children. That's not seen in Hong Kong or rarely in the reports from China as well. But in UK, for example, last time I came across their study, they had say about 80 cases of this MISC, and the majority really are the Caucasians and the Africans rather than Asians. I'm not sure about the Indian ethnicity in those in that study. It seems that they also have Indians in their children suffering from MISC in that study, but very few or not really that I remember. They had children with Chinese origin in that study. Okay, so I would think that genetic makeup of the individuals should have some bearing on the of this presentation of MISC in that study. I had also told you in Hong Kong so far, over the 12,000 cases we have the COVID-19 in Hong Kong, very few children had been involved, in fact. And with all the children or adolescents that have been infected, none of them have MISC. The only patient with MISC in Hong Kong is an adolescent, 12 years old, from Russia. You know, so I really have to concur that this with Dr. Chong, that this might have a genetic issue in the involvement. And that's why for the, even in Japan and in Korea, that quite a number of patients now again have been infected in the fourth wave in Japan, according to the news. I guess they didn't strike me with the number of patients with MISC or I don't know about thromboembolic events or the clotting problems in Japanese study. I just wonder if Marie could have any information about this. But definitely from the Chinese reports last year, from when they were still suffering from the epidemic there, I guess they also had the report of very few MISC, as I had remembered. So I wonder if we could ask our Taiwanese colleagues, especially, I guess this should be one of the big topics that we are going to discuss in the coming General Assembly, if there could be one in September.
So I take it other way around. If there is a virus, virus can behave like a virus. Virus can cause inflammation. Virus can precipitate inflammation, or body can react as a inflammation and then can be thromboinflammation. So I think the ethnicity will decide how do you react to the virus, inflammation, and thromboinflammation. So these three complications may be different from country to country, I can understand. Maybe I can request Dr. Chong to give a presentation next time about these special countries with the lowest complications rate. So you can pick up China, Taiwan, South Korea, you can pick up Japan, you can have Singapore, Hong Kong, and many others, and try to find out if we can come out with a common number that something is there which is preventing these types of complications.
Yeah, in fact, Dr. Chong, could you, I mean, KK also, could you get more information from Malaysia as well? I guess Malaysia is interesting as a country. They have 60 to 70% Malays, and then 20% Chinese, or 10 or 15% Indian ethnicity. Is that right? So they also could have some observation into the different behavior of different ethnic groups in the infection and the complications of this infection, COVID-19. And even there's 10 million Chinese ethnic citizens in Indonesia as well, although we don't have the contact with the Indonesian colleagues here. But then I imagine if Harvard or Johns Hopkins could have the study of the different ethnicity in America, that would be great. But I haven't come across such studies. I don't know whether the president you have come across. If there were, then they could shine light on our understanding of these different behaviors in different ethnic groups towards the COVID-19.
So as the time will less, I'll hand it over to Dr. Chong to ask everyone to give a 1-minute analysis of their country so that we can finish in time. Over to Dr. Chong. Ask every country to talk about what they have to offer. Starting
Thank
from,
you, President.
Yes.
So we'll start with, can we start with Dr. Jamal?
Thank you, Dr. Chong. Actually, in Bangladesh, now we are seeing more. That is almost South African variant is waiting here. And the presentation is a bit different, actually. Different means sometimes it's only the fever and even no cough. And the patient are getting unwell too early. And previously, 3, 4, 5 days were or more than that to have the pulmonary complication. Now it's getting early. And so the people are not actually getting time to go to the hospital also. Before that, they are getting serious or critical in critical stage. So the thing is a bit different here. And so we are getting more infections here, more spreading, and also the number of cases, the death cases are more actually now surpassing 100. Yesterday it was more than 101. So it's a record one now till the COVID actually came here, and it's more than 100 now. So we are very much worried here. And now the lockdown is going on, but it's not, you can say it's not 100% straight lockdown. Somehow slackens here. So is the situation now here? Thank you.
Thank you. Angelique, do you have anything to say?
Yes, thank you so much. In South Africa again, as Dr. Atkar said, nearly 300,000 people vaccinated. We don't really have seen these complications that much. We don't have reports currently of breakthrough. Remember, that's why we choose Johnson & Johnson because of our specific variant. We also are seeing our reported death rate on COVID-19 still stays around about an average of about 70 per day. And our cases this last 3 or 4 days slightly increased to about 1,300 plus. So where it was under 1,000 for the past few, past week, post Easter weekend, we will see what's going to happen. And South Africa is in the same situation. We cannot discard Johnson & Johnson because, it's an easy vaccine. It's the vaccine that is effective against our variant, against severe diseases. And, as KK right in the beginning said, we need to do benefit and risk evaluation. And again, it's not compulsory. So we are going to try to say to the people out there, listen, you need to determine your risk, but we would, prefer if you can carry on with this. I think with the ban or the temporary suspension of Johnson & Johnson will hopefully be lifted by next week, and so that we can carry on with our program. I just want to say, KK, there's 2 new variants in India. Maybe that's part of the problem that you are now seeing with breakthrough COVID-19, post-COVID-19 infections. Thank you so much.
What is happening in India? We have a UK strain in Punjab, the virus seen in which is 501V1. Then we have some very few cases of the one which is present in South Africa and Brazil. Similar to the South African and Brazilian virus seen there, we have a virus seen called 484452 double mutation, which is also 2 mutations occurring in the RBM. So it is likely to behave like the virus in the South Africa, not the virus in the Brazil, because Brazil has a very high mortality. Our mortality is not that high level of Brazil mortality. So one thing we are expecting, double mutation in India will behave like a wave, what happened in South Africa. And then we have a virus coming in India, which is causing E gene target failure. RT-PCR is coming negative. The person has a virus. We still don't know how it is behaving in India. And we still don't know the pattern of the double mutation which is coming. But observations wise, what we are getting a large number of cases or fever is very higher than the first wave. The magnitude of fever is very high, not responding to treatment, number one. We are also getting lots of patients of systemic inflammation, like MIS in children. We are getting MIS in adults, very high fever, very high CRP, and they have no pulmonary involvement. So these are the cases which we have started getting. We are also getting some cases of ear deafness, which was very rare in the first time. We are getting transient ear deafness occurring as a presentation in the second wave. And then we are getting involvement of children. Children are less than 10 years of age. The wave is, and it is expected. Virus will always mutate to a naive population. So coming to the children, I am not unexpected. It was expected move to come for a virus to mutate. Mortality is 50% less than the first wave. The mortality is 50% less than the first wave. Is it better treatment? Is it early diagnosis? Is it A virus which has caused, I don't know. Over to, let's also listen from Dr. Matanda Pillai, if he's there.
Thank you, KK. Your summing up of what is happening in India is very correct. We are going through a second phase, which is much more serious. And RO in the first phase used to be 1 or 2. Now the RO is 4 and more, which indicates that transmission from one person to another, the number of persons getting infected from one person, the number is definitely going up. Even the doubling time, which used to be 28 days, now it has come down to 10 days. So the doubling actually happens in 10 days. And there's a sharp increase in the number of cases. And as you rightly pointed out, the UK variant is much more present. The African variant is to some extent present, and the Brazilian variant definitely in digit numbers. But the double mutation is peculiar to India. The number is very high. And the clinical presentation definitely is also different. The high fever and even the throat swab, without infecting the throat, the chest infection or pneumonia is definitely happening. A lack of taste and abdominal problems are much more. The typical presentation is not happening with the COVID. It is a somehow altered presentation, maybe because of the mutant. But then even the mutants, the total number, which wherever the study has been done, is not very high to blame the mutants for the drastic increase in the number of cases. Even thromboembolic phenomenon is much less after the vaccine. Post-vaccine COVID is definitely happening even after 2 doses and 14 days. But more than that, second infection, almost 4.3% of people who had COVID are again getting reinfection. And that is a worrying factor. And that too in spite of vaccination. So this is a scenario through which we are going through. And the protocol of treatment is definitely remdesivir for 10 days. If D-dimer and ferritin is high, definitely anticoagulants, non-heparin anticoagulants are being administered. And if the D-dimer and CRP are high, steroids are being given, that too from the very early stages. Administration of steroids in the early stages itself, particularly parenteral, definitely is bringing down the morbidity and mortality. So this is a scenario, but the one distressing factor is that the COVID protocol is not being adhered to by our population, particularly when there is a festival, Kumbh Mela and things like that. Even the election is definitely one reason for the increase in number of cases and spreading of the infection all over. So that aspect, definitely as far as India is concerned, has to be reinforced. COVID protocol, wearing of the mask, keeping the distance, and hand washing has to be rigorously, religiously enforced. Thank you.
Thank you, Dr. Pillai. Deborah, do you have anything to say about what's happening in Brazil?
Hello. In Brazil, we have a high mortality, but now we are happy because we have a new health minister. He's a medicine doctor. He's a scientist. He's my friend. He's my close friend. And I'm very, here in my state, the cases are decreasing. It's we have about five states that are decreasing the cases of COVID-19. One of them is my states. We didn't have vaccine for a good number of people because we don't have vaccine for all. The new minister bought a great number of vaccine from Pfizer, and here we have we have a CoronaVac, is the Covaxin here, the same of Covaxin, and we have the AstraZeneca too. Only now we have only these two kinds of vaccines to the people here. I took the 2 doses from CoronaVac, but I'm continuously afraid and wearing masks and I'm very how can I say? I have a lot of caution.
Yes. Thank you,
And I
Deborah.
think, and I think until the end of the year we have many people vaccinated. Thank you.
Thank you, Deborah, for that update. Dr. Sajjad, do you have anything to say about what's happening in Pakistan?
Mr. Chan.
Can't hear you.
In Pakistan, we have been vaccinating people more than 1 million with the Sino vaccine. But the situation
But this connection is not good.
Dr. Sajjad, we can't hear you.
It's not so. Hello, can you hear me?
Yeah.
Hello?
No.
Dr. Chan, can you
Sometimes.
hear? Hello?
It's better now.
Dr. Chan?
Yeah, better now.
Yes.
Better now.
Hello?
Yes.
Okay. Dr. Chan?
Yes.
Maybe there is some signal problem. I just want to know, I just want to tell you that in Pakistan, we have facing the third waves of coronavirus, and which is very much, serious because of the having the UK variants, Brazil, and the South African variants. And because of that, a lot of patients here, particularly in 3 provinces, we have a 4 or 5 province, but the 3 provinces, particularly in Punjab, we have a lot of patients, and the deaths are increasing. The number of deaths are increasing day by day, and of course, the people are having these vaccines. With the few people of reluctant to have these vaccines, the government is, of course, doing its best. Just for vocal to follow the SOPs. There is no forcing. They can't force them to implement the SOPs. And the people are same as Dr. Chaudhary Jamal said in Bangladesh. The same is here. The people are very much reluctant. People are very much careless. They are not bothering about anything. They are listening everything that the people are dying day by day, and the people are suffering from coronavirus. The number of suffering people are increasing, but still we have a problem trying to just involve people, and just as a organization, as an association, Pakistan Medical Association, we have been very much vocal in through print and electronic media. And lastly, I must appreciate, as usual, to our president, Dr. KK, for presenting a very informative material for us, so we can just very much help. We have a very fruitful knowledge, and we imply here in Pakistan also. Thank you very much, Dr. Chan.
Thank you, thank you, Dr. Sajjad. Marie, are you here, Marie? Can you say something? Marie, something?
Thank you very much for always. And now in Japan, we experienced the fourth wave, the mixture of the South African variant and the English variant too. But fortunately, we test the people are about 4,000 people has been tested every day, but it is quite low compared with our population, and only 30 to 40 people are die in a day. So, and also the only 1% of people has been get the COVID vaccination. Luckily, I made a reservation of the vaccination on the end of this month. And unfortunately, the government still thinking about holding the Olympics. So we are pretty much worried about what will happen. So the prime minister announced that every athlete will do a PCR test every day.
Wow.
Yeah, but we are not sure who is going to be handle it or so. But thank you very much for every time. See you next week. Thanks a lot.
Thanks, Marie. Alvin, do you have anything to say about Hong Kong? Alvin? Alvin, do you have anything to say about Hong Kong? Yes.
Yeah, thank you, Mr. Chairman. In Hong Kong, basically the fourth wave is being controlled, well controlled now. Every day there are only 1 or 2 cases, local community cases. Most of those daily cases were imported. But the danger is that we still have 1 or 2 cases every day that's without known origin, with no known origin. And that means there are still hidden cases in the community that could spread around, especially when there are more than 10 cases of imported confirmed COVID-19, and that's worrying. And some of them, imported cases, are of the mutated variant, and the government must vigilantly block the entry of these dangerous mutant variants, especially from those, say, the Philippines or from South Africa or India or Brazil. But of course, having said that, in fact, the border is closed anyway. What I mean is, when there's case, the citizens coming back from these places, they must be well contained and mitigated not to spread to the local community. Otherwise, that would be disastrous. And right now, we didn't have more cases dying from the infection as many as a few months ago. So I think basically is optimistic now. However, the vaccination progress is not good. So we are envying the progress in Singapore. You have been vaccinating more than 2 million people, right? But in Hong Kong, at least 2 million doses.
Yes, that's right. So just to update you, in Singapore, I think we've hit about 2 million doses of vaccine out of 5 million population. And we basically are doing about 40,000 every day. It's all going quite smoothly. We're now vaccinating people from 45 to 60. When we finish with this group, the next group will be younger, those below 45. That will be probably end of this month. And so that's going along nicely. Number of cases, we just in the last 7 days, we had maybe 5 cases, 1 a day, sometimes 0. Yesterday there was 2. So all these are they are known contexts of imported cases. So we kind of know where they're coming from. They're not de novo. So that's what Singapore is doing. Okay, is there anybody else I've left out? If not, then we usually would like to call a close to the meeting. Is there anybody else that we have missed out? I don't think so. All right. I'd like to thank President again for always his hard work in assembling all this knowledge for us and putting it on a plate for us. That's amazing. So really much appreciated for all his hard work and research. President, anything else to add?
Thank you. We'll see all of you next week.
Thank you.
Thank you very much, all of you.
Thank you.
Thank you.
Thank you. Thank you, President. Thank you very much. Thank you, colleagues.
So, Sora, are you there, Sora?
Thank